On the second page, there is a PEDS head trauma protocol, but there's no second page to it. So I put a lot of information on here that also applies to PEDS about concussions. And this is a really, really hot topic and has been for several years now, especially in pediatric athletes. But this is like a list of common things that you'll see with concussions. These kids absolutely need to be seen for several reasons. One is because it's a requirement now that student athletes who have a concussion get reported to the state. So we have to fill out a form just like we do with dog bites. The other thing is that these kids need to be followed because they can have symptoms for weeks to months after a concussion, and they really can't return to any kind of sport that has any kind of contact sport until they're completely symptom free, because that's when you see the really bad outcomes with head injuries. Most hospitals now have clinics that specifically follow these kids. They have concussion clinics. And that's really important because it's important for them to be seen until they're symptom free, so that they're not playing sports. But the other thing is that a lot of times these kids need notes for school because they may need like extra time for work, and they may need to have shorter school days and that kind of thing until their concussion symptoms go away. All right, so now we're going to get into the PEDS airway protocols, and really the only difference on these is the fact that you can't RSI kids and that they get a needle crike instead of a surgical crike. Definition of a failed airway is the same. The option for Versed post-intubation is the same. This is just a weight-based dosing, but there's really no difference between the PEDS and the adult. On the second page, there is some information that is specific to PEDS, primarily about how to position the patient and why their airways look different until about the age of 8. About the age of 8 is when you get physically an adult airway. There's a formula on here for estimating the size of the ET tube. It's a little bit different from what you guys see a lot of times in paramedic school, and the reason why I like this formula better is because it makes it obvious that you start with a 4.0 ET tube. So a full-term newborn gets a 4.0 ET tube, and so that's why you start with a 4 here, and it's their age divided by 4. So this is the same formula as the 16 plus age divided by 4. It's just the 16 is already divided by 4. So it's the same formula. I like this one better because it makes it obvious where your start point is. And I'm going to change the parentheses at the request of Brian. He thought it would be better to have the parentheses moved to the outside of this 4, so it makes it obvious that you divide by 4 first and then add the 4 to it. Pediatric failed airway, still no difference. You can, if you can't place an airway, you can just go back to the bagging the patient. Needle crike if you absolutely have to. Hopefully you'll be able to get away with the BVM. Pediatric pain control, there's no difference between this one and the adult one other than the fact that this is weight-based dosing. So you still have the option for ibuprofen or Tylenol for mild pain, and then morphine or fentanyl for moderate to severe pain. So asystole EPEA for peds is the exact same as the adult. The epi bolus is weight-based, but the drip is not. Peds bradycardia, same thing. You can also use atropine for bradycardia. But there's no difference on this protocol from the adult one. The CHF pulmonary edema in kids, there's no difference between this one and the adult one either. So you may need to exit to the airway, you may need to exit to the allergic reaction protocol. This is another one that is just exit to other protocol. So for this one, if they're less than 30 days old, then you go to the newborn protocol, which the only difference is that they get chest compressions for heart rate less than 60. And then they've got the age on here. So if they're 16 or older, then you go to the adult cardiac resuscitation protocol. The tachycardia protocol, there is no difference between narrow complex and wide complex. There's just one protocol for kids, which they could have done on the adult too, because it's all the same treatment basically. So SVT, they get adenosine, and then if they don't convert, they get amiodarone. And if they have a wide complex, it's the same thing. Magnesium for torsade. And then PEDS VTAC and VFib, there's no difference between this and the adult protocol other than the weight-based dosing. It's still amiodarone, and then if that doesn't work, lidocaine. Post-resuscitation, if they have return of spontaneous circulation, then you can put them on an amnio drip. They can get Versed and fentanyl if you had to intubate them, and there's really no big differences on this one either. On the second page, because it wouldn't fit on the first page, it's also got where you can give morphine or ketamine for post intubation sedation. Peds allergic reaction. So this one is actually going to change once we get the approval to for first responders to give epi that's not an auto-injector. That's in the works, so hopefully within the next few months we'll have that going. So epi, Benadryl, albuterol, Solumedrol. Peds altered mental status. This is another one where you exit to other protocols wherever appropriate. Peds diabetic protocol. There's no difference between the adult and the peds other than the glucose that you give depending on age. So this there are several different guides that you can use for how to give glucose to kids. I like this one because it's easier for me to remember without looking at anything. So this is called the rule of 50, and the reason is because when you multiply each one, it's 50. So 10 times 5 is 50, 25 times 2 is 50, 50 times 1 is 50. So if they're less than a year, then they get D10 at 5 mLs per kilo. If they're 1 to 2 years old, they get D25 at 2 mLs per kilo. And if they're greater than 2 years old, they get D50 at 1 ml per kilo. And that just explains that on the second page here, rule of 50. Again, it talks about insulin pumps, DKA, patient refusal, same as the adult. Hypotension and shock, there's no difference between this one and the adult protocol, other than the saline is weight-based. Ingestions, also the same as the adult, Narcan if they need it. And then it's got all the different treatments for different overdoses, and same thing on the second page. The only thing different on the second page in the PEDS protocol are this little section here, pills that kill. So single dose that can be fatal to a pediatric patient, and there's a list of medications that can do that. Pediatric respiratory distress. This is the one that has the nebulized epi on it. So albuterol, you can add ipratropium if you need it, Solumedrol, and then they can get nebulized epi if they're not responding to the albuterol. And the way that you mix it, you use just the 1 milligram vial of 1 to 1,000 and mix it with 2 mLs of saline. You just put it in the nebulizer just like you do the albuterol. Ped seizure, there's nothing different on this protocol from the adult other than the fact that the dosing is weight-based. Same thing on the vomiting. Zofran, there's no Phenergan for kids. Yeah, so the Versed you can give IM, but the Valium you give PR if you need to. So pediatric head trauma, this is another one where you exit to other protocols if needed. There is no second page on this one, so that's why I put all that concussion stuff on the adult one. Multiple trauma for peds, same thing. It's more of a destination protocol. Splinting if appropriate, saline if they're hypotensive, needle decompression if they need it. You know, every hospital is different as far as like what they consider a trauma code. But the designations, like Baptist is the only level 1 trauma facility, and really should be getting all the peds, you know, serious traumas. I mean, basically anybody that you suspect has a really serious injury needs to go to either a level 2 or a level 1. I mean, really can't do a whole lot for them at the smaller hospitals. Right. Yeah, that's what I'm saying. Any peds needs to go to Baptist. So, you know, it certainly is complicated to get these patients transferred there from a small hospital. And then sometimes you just don't know. Like I had one the other day that actually looked pretty good and had some back pain, but had chronic back pain, and she wound up having a sternal fracture and an L5 burst fracture. And I mean, she looked great, so you just don't know. And you know, those aren't usually a problem getting them transferred because all they're going to do is, you know, admit them and get ortho to see them for their back anyway. So, you know, it's not a problem taking patients like that to the smaller hospitals, but anybody that's got any kind of signs of, you know, shock or, you know, multiple long bone fractures, any kind of like, you know, indication of head injury, altered mental status needs to go, you know, most likely to Baptist or Cone if you're closer. The biggest problem with those patients at the smaller hospital, well, there's a couple of things. One is that you don't want them to become unstable and then have to transport them. because that can definitely be a problem. But the other thing is that a lot of the time they wind up getting a complete reworkup at Baptist because they either, feel like our radiology reads aren't, what they need or whatever. So they get completely scanned at our hospital and then they get completely scanned again at Baptist. And it's certainly not good for the patient and can cause some problems. So yeah, I would say err on the side of caution, and anybody that you suspect has a bad injury needs to go to a trauma center. The peds thermal burn protocol is the same as the adult, and you can see on here, this is the way that the state wrote the formula. It's 0.25 per kilo times the total body surface area per hour. I think this makes it really confusing about whether or not you're supposed to multiply or divide, because even though it's 0.25 per kilo, which means you multiply, it's not obvious on the way that they wrote this formula. So I'm going to change this one the way that the adult one is. So this is a adult and pediatric protocol, and this is like for your mass casualty scenes where you designate who's immediate and who's minor and how to triage those. This is more than just your tooth pain. This is like when, somebody has an injury and they have a tooth that's avulsed. It talks about, putting the tooth either in milk or normal saline, controlling bleeding. Nosebleed protocol. There's no change in this one. So Afrin, direct pressure. And then you can't use Afrin if their diastolic is over 110 or they have coronary artery disease. The fever protocol. You can give ibuprofen or Tylenol if their temperature is greater than 100.4. Police custody. This is not for your behavioral patient that you're hoping police will help hold them down. This is more for your patient who got arrested and got pepper sprayed or got tased, and how to treat those. You don't have to transport patients that get tased unless they get a probe in their eyeball. So this is the protocol that I was talking about with Indwelling Lines. So your dialysis lines, they're PICC lines. Sometimes people have central lines for other types of infusion, like Flolan for pulmonary fibrosis. We are going to get some Kelly clamps for you guys to be able to clamp these off if they are bleeding. Sometimes these catheters will get holes in them. I did have a patient one time whose PICC line got cut in the middle of the night and bled out from it, so they can have, even PICC lines can bleed a lot. So you may have to clamp those off. If they're bleeding from around the catheter, just direct pressure to it. And then if you suspect an air embolus, then place them on their left side with their head down. The respiratory distress with a trach. So there's different things that are on here about troubleshooting it. The main thing that you need to remember is that if there's nowhere to put air into the trach, then it does not have a cuff. So you're not going to be able to create positive pressure. So sometimes patients with a trach will develop pulmonary edema or other respiratory problems. They get pneumonia, and you may need to bag them. If they don't have a little bladder to inflate air into there, there's no cuff, so it's just going to come out all around it. You can't create positive pressure. I've seen it several times where I had a patient one time that came in with a Jackson, which is a metal trach, and they were bagging it and it was just blowing out all around it, and they said, well, we think the trach's dislodged. Well, it's not dislodged, it just doesn't have a cuff on it. So you may have to take their trach out and put a 6.0 ET tube in there or whatever will fit, so that you've got a balloon that you can inflate so you can create positive pressure. Sometimes usually patients at home won't have this, but in the hospital sometimes they have a cuff that's deflated and you may have to put air in it. But most of the time patients at home, their trachs will not have a cuff. So just remember, if it doesn't have a bladder on it, then there's no cuff. Emergencies involving ventilators, most likely you're going to have to take whoever manages their ventilator with you. Most of the time these are like routine transports to doctor's offices and things like that, and you guys don't get involved with these, but occasionally the doctor's office may call for transport to the hospital of a patient that's on a vent, and either their home health nurse or family member, if they're the ones that manage it, needs to go with you. Bites and envenomations. So this one is divided into bugs, snakes, and mammals. So for spider bites, really the only one that's going to make a difference here is a black widow spider bite, which actually doesn't have a lot of physical exam findings. It really doesn't look like much. But patients will get really bad muscle spasms in their abdominal wall, and it's very painful. So you can give Versed for the muscle spasms for adults or peds, and the peds dosing is on here. For snake bites, really not a whole lot to do with them. Just don't put ice on it, and remove any kind of constricted clothing, like rings and things like that need to come off the area because it's just going to swell, and then we're going to have to cut them off. For dog, cat, or human bite, not a lot to do with that.
Dr. Taylor, is trying to remember the physiology behind the ice. Does it make the venom travel quicker?
It doesn't. It just causes more tissue necrosis. So all of the snakes that you're going to see here are going to be hemotoxic snakes. So all the pit vipers are hemotoxins, and that causes basically the hemotoxin breaks down the cell wall of all the tissue. So the muscle tissue, the blood cells just bust open. So that's why you get a ton of bruising, blistering, tissue necrosis from those kind of bites. And the ice just makes that worse. So with snake bites, it is helpful if you guys can draw a line around where the redness and swelling is and put a time on there. And that way it kind of gives us a gauge of how bad the swelling is progressing. Yeah, so when you see the patient, just draw a line around where the redness is and write the time on it. Because we do the same thing at the hospital. We'll keep drawing lines. So in the next hour, we'll draw another line, and that gives us an idea of how quickly it's progressing, and that helps us judge whether they get crofab or not. Carbon monoxide and cyanide. So they're going to get oxygen and treatment for their hypotension if they need it, but the biggest thing is the high flow oxygen to replace the carbon monoxide. Drowning and submersion injury. So if they're awake and alert, just remove their wet clothing. There's really no difference in this one. If they have alterations in mental status, then you may need to go to another protocol. If they've got respiratory compromise, obviously, if they've got cardiac arrest, you go to that protocol. Hyperthermia. So this has a lot of information about the different stages of heat stress. So you get heat cramps, heat exhaustion, and heat stroke, and the treatments for each of those. And then if they're seizing, go to the seizure protocol. Hypothermia. It's got information on here about rewarming. You don't want to rub the skin because that causes more skin breakdown. So general rewarming, fluids if they need it. Probably not going to see a lot of this. Although I did find out from Brian that we have freshwater jellyfish in High Rock Lake. Had no idea. They're about the size of a penny. Freshwater jelly. Here, you can pass that around. I know. I'd never heard of it either.
Is the inventivation the same as the saltwater variety? Or?
Apparently they can be painful and they come in swarms. Like they tend to like swarm, but they're itty bitty. So now everybody's gonna be paranoid. Apparently stings are rare. I just thought that was fascinating. I had never heard. So we probably won't see a whole lot of these. You may actually see lionfish stings because people keep those in saltwater aquariums. Hopefully they're not petting them. But it's possible. They get calcium for that. And then, so everybody's gotten a good laugh out of this one. They've got large organisms on there, which I think are things like sharks. But basically, exit to trauma protocol if appropriate. So weapons of mass destruction. Atropine if they need it. We don't carry the 2-PAM anymore, so not an option. Yeah, I'm thinking if weapons of mass destruction happen, everybody's going to be having a really bad day, and lots of people are going to be intervening. So blast injury, you treat the burn, or there's a radiation. We haven't gotten to that one yet. Radiation protocol. There's a crush syndrome protocol that we haven't gotten to yet. So this is one where you can exit to appropriate protocol. Chemical and electrical burns. There's no difference between this and the thermal burn protocol. The main thing that you need to know with electrical burns or electrocutions is that you do an opposite type of triage with these. So most of the time when you've got a mass casualty triage, your patients that are pulseless, you're not going to treat because you're going to treat your patients that you think you might be able to help. It's the opposite when you have electrocution of multiple people, which we almost had recently. So with those, you treat the people that are down because you can actually get them back. When people get electrocuted, it causes not only their heart to stop, but it also causes a VFib arrest, but it also causes a paralysis of their diaphragm, which can last for 20 to 30 minutes. So those patients actually need to be worked for a prolonged period of time. The patients that are not unconscious, there's nothing you can really do for them or need to do for them. With electrocutions, for the most part, you're either fine or dead. There's no in between. So you really want to treat the patients that are down. So you do an opposite type of triage with them. Crush syndrome. So this is like an extremity that's been trapped for a prolonged period of time. What can happen with this is when the tissue is crushed, you're going to get some tissue breakdown, and all of that muscle fiber that has now died is going to release a lot of potassium into the bloodstream. You also get a lot of buildup of lactic acid in that area because you don't have blood flow to it, so you've got anaerobic respiration going on. So you get a lactic acid buildup and you get a release of potassium that's kind of trapped in the area until you release it, and then it floods the bloodstream with it. So you can get arrhythmias and a profound lactic acidosis with this. So what you want to do is give them fluid resuscitation, and immediately prior to release of the extremity, give them bicarb. So they get an amp of bicarb. And then you can give them morphine or fentanyl if they need it, and Versed for pain control. And then calcium for the treatment of the hyperkalemia. Yeah, everything on these protocols you do not have to call medical control for. So there's a lot of information on here about crush syndrome and reperfusion injury. Extremity trauma, this is mostly about controlling bleeding, applying tourniquet if you need to. Spine immobilization, so these are all the indications for spine immobilization. Please remember that just being in a car wreck is not an indication for spine immobilization. I recently got a email from High Point, and Kelly, this was one of your patients, that they were upset didn't have spinal immobilization, and I sent them an email back explaining that it was not indicated. And I will totally back you up on this if you guys are doing this appropriately. But it was a patient that the car had hit the guardrail and rolled on its side. The guy had no back pain whatsoever. He was completely conscious. He was not intoxicated. And so that, that's really not an indication for spine immobilization. You wouldn't splint an arm if there wasn't an indication, so there's no reason to do that for a spine. So on here are the indications to immobilize, and it has on here, if you have any, doubt about it, then just immobilize them. It's not a problem. But, so if they have any neurodeficits, obviously, if they're older than 65 or younger than 5 and have a significant mechanism. So age alone or mechanism alone does not require spine immobilization. They have both. And then alterations in mental status, intoxication, distracting injury, if they have point tenderness, all those, you guys know all this stuff. But, just because a little old lady fell out of her wheelchair doesn't mean that you need to completely immobilize her with her kyphosis and she's not going to be able to breathe and go into heart failure and all that. So immobilize when appropriate. Radiation incident, also probably going to be a bad day for everybody. Hopefully we will never see this, but there is a protocol for it. And it's the same as the burn protocol. And that is it. Do you guys have any questions?